to know more about the importance of electronic witnessing during the IVF cycle. We have two speakers today, Dr. Yousef Alhelou, the Group Quality Director for Fakih IVF, and Dr. Martine Nijs, which is the CSI Global Training Manager.
So thank you, Amr, for inviting us to present this webinar. This webinar will focus on electronic witnessing and try to explain to you why it is so important to have an electronic witnessing system in place. It will be in two parts. So myself, I will talk about the literature, what the pros and cons are of different witnessing systems. And then our esteemed colleague, Yousef Alhelou, he will then really explain how it works in the lab as a tool for management as well. So this is the agenda for today. I'll briefly discuss about medically assisted reproductions, talk about errors that are present, unfortunately, still in medically assisted reproduction, and then how we can work towards prevention of these errors. We will then zoom into the quality management using that electronic witnessing system, and here Dr. Yousef will give his experience, share his excellent experience with us. Then we also will look what operators, embryologists, clinicians, and even patients think about this witnessing system. And I will briefly touch on some other electronic witnessing systems and summarize. So I don't have to explain this to any of you, but medically assisted reproduction involves many, many steps. Starting in the clinic, where patients come for consultancy, for fertility workup, going through the different treatments that are out there, IUI, IVF, ICSI, biopsy of embryos, vitrification, etc., etc. And then hoping to result in that healthy pregnancy and a baby at home. These are all the ART treatments. Now, in your lab, one of these cycles in your lab, let's say an embryo is manipulated around 20 times by an operator, by an embryologist. This is during oocyte retrieval, transfer between dishes, tubes, denudation, washing steps, ICSI itself, for nuclear checks, media changes, biopsying if you do this technique, then cryopreservation, storing, warming, etc. So more than 20 times these embryos and oocytes are manipulated. So if you do around 100 treatments in a year, this means that with an average of 8 oocytes, these are 16,000 manipulations in your lab. And yeah, do you register your data in a national database? So this is a question for you. We are going to be a little bit interactive. So Amr, if you could start up the poll. So this is anonymous. Could you tell us if you register, how many cycles you do in a national or international database? So the answer is yes, no, or I don't know. And any answer is okay. So please send in your answers. And once you have the answers, Amr, you can share them with us.
Sure. A few more seconds with the receiving answers. Okay. Sharing the results now.
Yeah. So yes, 14% of you are doing this, 70% roughly are not, and some of you don't know. So this is really interesting to know, because why am I asking this? It all starts with having data, and I'm sure Dr. Yousef will go into that as well. These are some examples of a number of cycles. So like in Europe, we are obliged to register all our information into a database, a national database. That information is then brought to the European Union. And as you can see from the previous report, there are over 1 million cycles in 39 countries in Europe. So that's unbelievably high. And this is around more than 110,000 patients underwent a medically assisted reproduction procedure. So sometimes things can go wrong. You can imagine that high number of procedures, that high number of interactions of an operator with gametes and embryos. So what type of errors are out there? There are errors that are resulting from actions that are not taken. And this is really a simple example, not checking the temperature of the heated stage or checking the nitrogen levels in your tanks. So that can lead to an error, overheated or undercooling of your gametes, or thawing of stored material in the tanks. Errors can also occur as a result of a wrong action taken. So that's another type of error, when you do something that you're not supposed to do. Reusing pipettes for different patients, that's catastrophic. Incorrect labeling of tubes and dishes, and inseminating with wrong gametes. Now, these types of errors can lead to different types of non-conformances, and this could have a moderate effect, a significant or a major effect. And this is from the publication of Dennis Sakas and colleagues. So a major effect is, of course, a major error is when you mix up gametes, when you transfer the wrong embryo to the wrong patient. And there are less, so minor is, for example, when the wrong sheet paperwork is taken for the wrong procedure. The EU has also created a guide to the quality and safety of tissues and cells for human application. And here, if it's really serious, they listed those types. And it is mix-up or loss of traceability. Mix-up of sperms during the prep or the treatment, a sperm sample contaminated with another sample, oocytes fertilized with sperm cells from the wrong person, inseminating a woman with sperms from another, they call donor as a partner in the European legislation, and the wrong embryos thawed or warmed, or incorrect labeling, resulting into using the incorrect embryos and oocytes. Now, question to you again, does your center have an overview of the errors that happen during your IVF treatments? So again, Amr, please, if you could send out the poll, the answer could be yes, we have a system, we have an overview, we know what errors have happened. No, we don't have this, or I don't know if we have that system. So thank you if you would like to answer this, and Amr, please share with us the outcomes. Again, this is anonymous.
Few more seconds.
Okay,
sharing the results.
Perfect. So yes, 63% of you have a system in place to know what errors have occurred, to identify those. Some of you don't, and some don't know if this system is out there in your lab. So again, why am I asking this? It is really important to know the data. How many errors have occurred in your lab? How many near misses? Were these minor misses or were these major errors? And this again, I go back and over again to this overview from EU because the data is so important. You can see that you can make errors at any stage of the procedure. This could be during the processing, the storage, the testing, the culture, etc. But errors do occur. And this could be that the equipment fails, that the materials fail, that the system you're working in fail, or it could also be a human error. And this is the light blue bars. And you can see in each step, except for storage, there were errors in Europe for this. And it's really important to know what goes wrong, because then you can make a system to prevent it and correct it. Another interesting data set is from a study from Nesbitt et al. And they screened a lot of papers, and they found 8 inseminations with wrong semen, 6 transfers of the wrong embryo, 3 errors in PGT where the wrong embryo was transferred, and 5 failures of gamete and embryo storage. So we do publish about this. We also want to learn what is going wrong. And then what also was done was by legal people. So especially in US, there are a lot of court cases around. If something goes wrong, there will be a court case. And this is a search for mix-up, just by Googling mix-up of embryos, and in the database from the lawyers. And it seems that these were 14 cases, but it appeared for over 100,000 times in the newspaper in US. So this is also an important aspect, that not only the damage is being done to that patient, but also your clinics viewpoint will change. People will look different to your clinic. Do we make more errors than in the standard laboratories in the clinic? Yes, we make less errors, luckily. In the standard lab, like clinical, transfusion, etc., endocrinology, it's almost 0.5%. And here in our area, in IVF labs, this is around 0.10%. So we make, for sure, already less errors that have been recognized. Now, how can we prevent those errors? We have great societies and also laws and bylaws, and you can check these in these really great guidelines. I give you examples from the EU, I give you examples from ESHRE, also from the ASRM. You can find those, but they all come to the same conclusion. You need a proper identification system. You need to have identification and verification in place during critical steps. So you know you are using the correct embryos and gametes, and that the date and the time of each manipulation and the identity of those working with these gametes needs to be recorded. So if you have this quality system in place, an ISO standard, for sure this has already been included, that this SOPs for preventing errors and identifying those errors is in place. Now, how do you prevent, how do you check you're working with the correct gametes? Again, a question for you. Do you do witnessing? Do you do manual witnessing? Do you do electronic witnessing? Do you do both? And Amr, please start the poll. Or you don't know, or you have no witnessing in place. Again, this is anonymous, and it would be interesting to see how that works in your lab.
Unfortunately, Martine, this poll is not starting. There is an error with this question.
Okay, so then we will skip it, but it makes you think that there are different systems out there. And the first one, the traditional one, the old style, as we call it, is the manual, the 4 eyes, a double checking by a second operator. And this means, first of all, somebody will come and check if there is accurate labeling. There's one patient in one workspace, and then the 4 eyes, somebody will assist and check if the names are correct, or if you are doing in SIM, for example. This means you have different professionals in the lab that are doing this witnessing. You need really strict operating procedures. You need to train the team. You need to adapt your SOP and your patient file, and things need to be signed off. It needs to be confirmed that you have witnessed that specific step. That could be digital or in paperwork. But this could lead to incomplete checks. It has been documented that there is automaticity as well. You read what you want to read. This has been proven, and there is the Santos paper that shows that. There is also non-contemporaneous checking. And of course, you are distracting that second witness from another task that that person is doing. So this is not optimal. The other system out there is the electronic witnessing. And how does that work? At the start of when patients enter the clinic, they are being assigned a specific electronic tag. And at that point, there is manual witnessing, because you really want to make sure the right people are linked to the right electronic tag. And then during the whole procedure, this could be a barcode-based or radio frequency identification-based. All the gametes, tubes, dishes, etc. are labeled, have specific tags on them, so you can then make sure that the electronic system will recognize it and will tell you when you are going to do an error. So you're going to prevent the error. This can be at the insemination step, the culture step, when you move embryos from A to B, and during the biopsy, the transfer, and the cryopreservation steps. You also see where you are in your flow of work, which patient activities have been completed. So it's not only the witnessing, the data can be used to give you way more information on the workflow, the workload, and all these aspects. It is then logged into a database, and in this way you can prevent errors, make them not happening. How do you do this? Of course, you need to know all your steps. And for this, you have to have a workflow, an overview of your SOPs, and you need to identify those critical points. And most companies will help you with this, but you need to have that in place. So this is an example, it comes from the Gupta paper, but if you set this up, and Dr. Yousef can explain it as well, you have all these steps. For example, if you are doing freezing, then all these steps, and the green ones are the ones that are critical. And there you will have this electronic witnessing in place. So you have this traceability, you will have the documentation for each procedure patient, for each sample that you have used, etc. And you can track them also, the disposables. This can be added, again, other data. You can have stock management. This system will log what the expiry date is of your media, for example, or your other products, dishes, what is the shelf life? So it will give you a warning when you need to order new products. So it's much more than witnessing itself. Now, does it work? It's a lot of explanation, but this is what we looked at the literature. And just as a reminder, the manual witnessing, as proven by these different authors, the total mismatch rate is between 0 and 5%. If we look at when people have introduced electronic witnessing, the total mismatch rate over all the steps in the ART procedure are quite low, 0.29, 0.66, 2.6, and 0.25. The prevented true mismatches, and these are the real catastrophic ones, mismatch of gametes, a wrong embryo going to be transferred, so it's a prevention, the system will alarm you, this is really low. And especially here, the Sterks paper, this is over 840,000 cycles and witnessing steps, so that is really low, 0.017 prevention of true mismatches. So careful when you do electronic witnessing, you should not be overconfident in the system. What you have entered will be checked, nothing more, nothing less. But you can change that throughout when you work with it and you find more critical points. You still have to do manual witnessing at the entry and exit when you have this system in place. And you must be aware that you can make errors when you print labels if you should use those. So it will not prevent protocol drift. If somebody is not aligning with or working according to the SOP, practically, you cannot prevent that with electronic witnessing. But you will reduce the time of people doing witnessing. And this is a paper from the Holmes group. And the light blue bars is the time being used for witnessing at the time of ICSI, for example. And this is the manual witnessing. See, it's more than double the time that was being used for manual witnessing when compared to electronic witnessing. So you reduce the time using for the witnessing itself. You have to install the witnessing. There is a validation time, so you need to double run with manual witnessing. You need to train people, of course. There will be updates and maintenance in place. And of course, but it will be cost saving for your clinic. So data, as I explained, are really important. My question to you is, do you as an operator, as an embryologist, do you have an idea how many ICSIs you have performed last year in 2022? And it could be yes, no, and I don't know. So please give an answer. Again, this is anonymous, and Amr, when the questions are in, please share with us. So it's really you. How many ICSIs have you done last year? So Amr, do we see replies?
Few more seconds, we'll share the results.
Yep. So yeah, that is super. 89%, they know how many ICSIs they have performed, and one person doesn't know if that information is available. So why am I asking this? It's again about data. And here I'm going to hand over to my colleague, Dr. Yousef, to talk about that information. So Dr. Yousef, the floor is yours. You are going to share your experiences with us.
Thank you very much.
So I gave you control. You can forward the slides.
Yeah.
It's not working?
No,
Okay, no problem. Then I will forward. So please just tell me when you want to go to the next slide, okay?
okay. So Dr. Martine covered all the aspects of the witnessing. I am going to share my experience with the new feature of the RI witness. That's called the RI IQ witness system. This is the quality management system that analyzes all the work in the lab. Once the system is installed in the lab, it's able to analyze all the data retrospectively since the RI system was installed, and it will give us a lot of data about the location of witness and the analytics field procedure, like for each procedure when it started and when it finished, and it analyzes the times and work area and the time interval between the parts of each procedure, and it identifies underutilized capacity in each lab, and I identifies outliers in lab performance and optimize and even distribution of workload, and monitor the performance and metrics in a training in our new joining embryologist. So the RIQ system shows percent of total work per embryologist. Here I have example in one of the labs. We have 8 embryologists. It shows that embryologist number 2 performed 19% of all the jobs, and embryologist number 1 was lazy and did 1% of all the total work. And we can also see the workload distribution for each individual task in the lab. Here we can see.
Oh, sorry.
Here we can see, for example, the biopsy workload and the X-ray workload. We can see which embryologist did which percent. And this can apply to all the tasks, starting from media preparation till the embryo transfer. And all data can be exported for Excel for further research. Any data in the RI witness system can be exported in the Excel, where we can see any information we need, and this can be analyzed further for research and for additional data analysis. Next. The system helps to find points of weakness in the workflow. For example, here we have 10 mismatches in one location, and we noticed after analysis that there is the oversensitivity of the RI reader. It can read the plate, it can read dishes and tubes that are outside the reader, and this makes us to calibrate it and fix it so and avoid the mismatching. Other thing is we found there are many admin assigns. The admin assigns are happens when the RI system does not predict the next step in the workflow. So one of the senior staff need to dictate the RI system which step that should happen. And we found this in mainly in the frozen embryo transfer cases. And this gives us idea. And we were able to modify the flow chart and the map of the RI witness system, and we managed to resolve this issue, and this saved around like 1 to 2 minutes per embryo transfer, and this is really of the time when it comes to embryo transfer, like 1 to 2 minutes make a difference. Next, please. And it helps us to find the weakness of certain tasks. For example, this is the duration of denudation. We can find the average work per all the embryologists is around 6 minutes, but some embryologists take 14 minutes and other here take like around 30 minutes. So some people are take time more than the average, and some people are working ahead less than the average. And this leads us to talk to the staff and improve their performance to have all the work uniform and the timing consistent amongst all the staff in order to guarantee the best quality of work. Next, please. And it facilitates SOP and protocol review. Here we can see one task. Most of the people take like 13 minutes to achieve this task, and some people talk up to 30 minutes, 40 minutes. And from this, we noticed that some of the embryologists, like when we do X-ray of denudation or biopsy, they talk more embryos or eggs to perform at the same time, more than the recommended by the SOP. So we detected this issue and we managed to resolve it, and all the embryologists follow the same procedure now. So this gives me information more than when I sit inside the lab. I can access the information from anywhere and from any device. And we can compare the lab performance with the previous months and with other branches and show the results of a protocol change. Like I am the quality director of 9 labs, and I can compare, for example, the exit time in each of the lab, how long does it take, and compare it to the previous months and the previous years, especially when we change the protocols that are relevant to the timing and number of embryos and gametes handled at one time. So this was my last slide, I think.
Yeah.
Thank you, Dr. Martin, for giving me this chance. Now the floor is yours.
Yeah, thank you so much. Excellent information. And how you manage this for 9 clinics, it's amazing. But we can go in more detail during the Q&A section on that as well. And to add to this comes from the literature as well. Here is a study that the Adams and colleagues team did in US, where they compared the training times of operators, embryologists. So they compare the mean time for each procedure, and this depending on how long and what your experience is as an embryologist. And you can clearly see the longer you work in the lab, the more experience, the faster you do that procedure. Another example, and you mentioned that also, Dr. Yousef, is that you can use the data to do research. And these are 2 papers that were really nice because they used the timestamps that you have in the witnessing system to study how long, if there is a relationship between the time of the oocyte pickup and your denudation and your ICSI itself, and if that could correlate with more fertilizations, better embryos, higher implantation rates, etc. And they could see, for example, the relationship between time to ICSI using these data, the timestamps that you have in the witnessing system, that if you have the time between OPU and ICSI is more than 4 or 5 hours, you can see there is a decrease in your biochemical pregnancy rate, there is a decrease in your ongoing pregnancy rate. So that you can identify for your lab, for your clinic, but also for multiple clinics within your group of clinics. The other study that was done using the time stamping is the relationship between vitrification and how much time is needed, what is the optimal time to do your ICSI in terms of implantation, again, ongoing pregnancy, etc. And there we could see that there is a big window actually before you can start doing your ICSI. But I invite you to read the papers in detail, and we can send you the links to those references if you want. But the whole idea is just to tell you, be creative with ideas and how to improve your outcomes. And you have all these data, these timestamps, and they can help you do that. Now, what do embryologists think of this? What do clinicians think of the electronic witnessing once it's introduced in their clinic? And also patients, are they happy with this? Does it change their idea of their trust in a clinic? And this is a study by the Gupta group where they looked at the satisfaction graph of the clinician, the clinical embryologist, etc. And you can see that people are really 4.5 as an average on, they're happy, they're satisfied when a witness was introduced. And this was a questionnaire that they sent out. I know it's in small print, but overall, it says that the green bars is when people are happy. So you can see when witnessing was introduced, they really have a much higher satisfaction rate and feeling more confident in prevention of errors using the system. Then this is then about the patients, and this comes from a study in Italy, where at some time point, and this is the one here in the middle, there was in the newspaper, there was the mentioning of a mix-up of embryos during transfer. And this is how patients' concern was. So they were not so concerned about the treatments or errors, but when this appeared in the press, of course, the concern raised. And if we looked then at the witnessing, the confidence, the satisfaction when they knew the electronic witnessing was being used in the lab, they were really happy. You see there's a peak in satisfaction and feeling confident. Okay, this clinic has witnessing. I feel secure. I can go there and nothing will happen to no errors will happen in that clinic because of the electronic witnessing. So these are important data also to share with your patients that you are using electronic witnessing in your clinic. Now, to end up this overview, I will share with you some other systems of electronic witnessing, and these are really creative. I'm not sure if they're really practical, but I'm going to mention them anyway. So this is, for example, adding a barcode into a sample, semen sample, while it is being processed. This is one option. The other option is to laser a code of the patient in the zona pellucida. My question is then, what if hatching appears or a crack in the zona, etc.? So what is the influence of the lasering? So these are question marks with these techniques. And the second group is here when they injected barcode systems under the zona pellucida. And they try to detect, here you have several, they are gluing them on the zona. So these are other varieties, but they are so extremely labor intense. So I think the standard electronic witnessing that has been developed is a great, great asset. And then to summarize, before we open the Q&A, I think it is clear from the legal paper where the lawyers reviewed what is really working, what are solutions to prevent human errors. They also identified that labeling of all your materials, tubes, dishes, etc., but also identifying and using the electronic witnessing, in this case, radio frequency identification system, is proposed as the best by the legal. So not only by us scientists and embryologists and clinicians. So thank you for listening to us, and I can now open the Q&A. So I'm going to stop sharing. And I think Mark will take it from here.
Yeah. So we have some questions I encourage everyone to ask. Does electronic witnessing system consumes more time than manual? I think this is for you, Martine.
Well, it does consume time when you set it up. And maybe Dr. Yousef can comment on this, how long it takes to set it up in your clinic. But from the data that I showed, it's clear that it takes less time than manual witnessing. You don't need to call and wait for a second person. This second person doesn't need to take a paper to tick or open a program or whatever. You are working, the system recognizes the tubes, the dishes, whatever, and you can confirm. It's very fast. Yeah. So Dr. Yousef, maybe you can comment on that initial phase, how long that takes, roughly.
At the beginning, it will need some time to train the lab staff, but after that, it will not take any time. Just the second you put the dish on the reader or the tube on the reader, it will appear on the screen the name and the details of the patient. So it saves a lot of time and effort.
You do have to label those dishes and tubes, but you were going to label them anyway, even if you use a manual system. You were going to write, and writing, you can make errors. Here with these printed RF tags, you can't make a mistake. So yeah, but from the data, scientifically, it's clear there is a win in time.
Great. So next question, how does the system help in assuring SOPs are followed in the lab?
Well, I mentioned that you cannot avoid protocol drift, but I just learned from Dr. Yousef that you can. So in one of your last slides, you identified people taking too many eggs for ICSI, or please, can you elaborate again?
We noticed that from the time in XP and also all the other processes. For example, our protocol is to inject 5x per time, and we noticed some embryologists that take more time. And when we observe the process and we discuss the issue with them, we discover that they take more than 5x, like 7 or 10x at a time. And we talked to them, and they complied to the protocol. And this applies to all the steps, starting from OPU till ET, including biopsy, denudation, and other things.
Yeah, and to really avoid protocol drift, you have the observation, you can use the data, but to really make an inventory of details on protocol drift, you need to do internal audits. So that's where you will check all your operators doing an ICSI according to the SOP. You can write down what is deviating and then sit with your embryologist and say, hey, you had the best ICSI outcomes. You were following the protocol, so how will we manage those that are not following the protocol on this small item? And it could be small things. It could be taking longer, higher concentration of sperm in the PVP or lower. So it is, yeah, you need to still do that in-depth follow-up, I think. The witnessing will help you for sure to manage and to go and see, oh, there is a weakness, as you beautifully described, Dr. Yousef. And then you can go into detail and do these audits.
Yes, that's right.
The next one also for Dr. Yousef, I think. Was the implementation of the system in the lab easy? And what was the learning curve of using the system for the embryologists?
For the RI system, it needs time for the planning and mapping and installation. So the planning process took around 1 month. The installation per lab, I think, took 1 or 2 days. And the mapping, it took around 1 month. The installation per lab, I think, took 1 or 2 days. And the mapping, it took around 1 or 2 days. And the installation per lab, I think, took 1 or 2 days. And the For the training period initial, the engineers were with us most of the time from CooperSurgical, and they were training all of us. Like within 2 to 3 weeks, everybody was competent and comfortable with using the system, and happy with that because everybody noticed the difference. Regarding the witness IQ system, it's a cloud-based, and the access can be granted in 1 minute. And it is also very safe, though data is analyzed in the cloud, but it doesn't take any patient in names or file numbers or any confidential data about the patient. They just deal with numbers. For example, if we do X-ray today for 10 patients, the system will analyze the number for 10 patients without knowing the names and the time taken for performing the X-ray, without knowing any confidential data and without storing anything in the cloud. So all the data remain within the lab.
Thank you. Next question, how can we apply it for freezing and thawing procedures? I think question is about if we have an RFID or barcodes.
Yeah, we implement for the freezing and thawing. There is a special label that can be used in liquid nitrogen, and it has a barcode, it has all the patient details. And before we place the sample in liquid nitrogen, we have this label affixed to the straw or to the vial, and it is not affected by liquid nitrogen. And also we can number the embryos and the sperm vials. So if we freeze 10 embryos at a time, we can give the number of the embryos 1 to 10. And after we receive the PGD result, if the embryos are biopsy, we can enter into the system that this embryo is normal and the other is abnormal. So at the time of thawing, the system by itself, it will recognize this is a normal or an abnormal embryo, and which embryo is thawed. This applies also for the sperm. We can give numbers to the vials, depending on the date. Also, we can, for example, if we have a patient that have more vials in different dates, we can differentiate which vial was stored in which date, and upon the time of thawing, the system can know it easily.
Great. So in case of errors, how it is working, and is there any possibility to escape the alarm in case of errors?
Yeah. For example, if you have 2 embryos frozen for one patient, one is genetically normal and the other one is genetically abnormal. So when you do the thawing, before you take the embryo from the liquid nitrogen, you can read the patient information by the barcode reader, and it will recognize the patient details and also the embryo number and the genetic result. So, for example, if an embryologist by mistake takes like the genetically abnormal embryo, the system will give an alarm, and red tag, visible and legible alarm, and it will tell you are trying to take the abnormal embryo.
Thank you, Doctor. Doctor, are you using it like an audit system? Can we use it as an audit?
Yes, sure. You mean for the frozen samples?
I mean the whole system, the electronic witnessing. I think.
Yes,
I'm not sure
yes,
who asked the
yes.
question.
We do
Yeah.
it we do use it for audit for all the steps. And also we use it to audit the consumables and media as well. So it can be like there is numerous data, countless data in the system that enable the user, especially the seniors one, to monitor and audit all the steps of the work.
Okay, thank you. In cases of system failures, I'm not sure if you had any, but is there a protocol that you use, an SOP for system down or something?
Yes, as a part of CAP accreditation and GTI accreditation, we do a drill called downtime drill, and we did one last week. So once the system fails, we transfer immediately to the manual one. We have the paper and necessary documents, and we work, and we do use the manual system and write the related documents. And once the system is back, we upload the data into the system.
Great, thank you. And also, I think the last one is you already answered this. That can we access the lab info remotely, or it has to be from inside the lab? And who can see this information?
For the RI witness, it can be accessed within the same group, but for the RI QI system, it can be accessed from anywhere. Like when I am outside the lab on leave or on attending a conference, I can check it from my mobile phone. The accessibility is granted to the senior staff. Like it determined for me as a director, I can grant access to my senior staff and can delegate them to observe uh, some of the information in my absence, or to edit the information and report it to me.
Thank you, Doctor. I think that's it for the questions, Martine. So,
Okay, super. Thank you so much, Dr. Yousef. It's really great to get insight in the user's world. And I'm handing over to Amr.
Yeah, thank you, Dr. Martine. Thank you, Dr. Yousef, for joining us today and sharing your experience and this valuable information. Thanks, everyone, for joining. You'll receive a short survey, anonymous one. We appreciate your feedback and looking forward to seeing you next webinars. Have a good day.
thank
Thank you
you.
very much.
Thank you.
Thank you.
Bye-bye.